Welcome, everyone. You've joined the Flex Quality Networking meeting through the Medicare Beneficiary Quality Improvement Project. And my name is Becky Royer, and I'm subcontracted by IHA in the State Office of Rural Health to lead this particular work. And so glad that you could join today. I do encourage you to hover at the bottom of your screen and open up chat and open up the participant list. Everyone is muted as they enter the program today, but definitely as questions arise, please use that chat function by clicking on that icon and typing in your question. Allie Orwig with the Indiana Rural Health Association that helps support Zoom, which we so appreciate, and myself will be watching chat to make sure that questions are addressed. Or you also are more than welcome to unmute your line, and you can do that easily by hovering at the bottom of your screen or where your taskbar pops up and clicking on the mute microphone button and unmuting yourself, or you can also do it by your name if you've clicked into that participant icon and can see everyone that is on the call. So encourage you to do that. We are so privileged today to have Sandy Sage with us. Sandy is from Hometown Health. She's a registered nurse that does a lot of work with rural hospitals across the country and has a lot of rural health experience herself, and does also a lot of revenue cycle evaluation and technical assistance with rural facilities. So I have included her bio in the calendar invitation for today. I'll also let Sandy provide a little bit of her background that she would like to share with you too. And there also are some continuing education credits available for today, and Sandy will review the criteria to be able to receive that as well. So without further ado, because there's a lot of content to cover today, I'm going to go ahead and turn it over to Sandy.
Thank you, Becky. Hello, everybody. Thank you guys for being on. I really appreciate you joining us today. Today, we're going to talk about care coordination considerations for case management in the emergency room. And I'm going to tell you a little bit about myself that'll make some of this make a little bit more sense. First, we want to do a disclosure of proprietary interest for you guys. Hometown Health has no proprietary interest in any product, instrument, device, service, or material discussed during this program. All images, templates, and themes within this presentation are utilized with permission and in keeping with copyright compliance and all rights reserved. So, as Becky said, I am a nurse, and I actually was a nurse manager in the ER for many years. I can't believe it says I've been a registered nurse since 1990. Oh my goodness, that's probably before a lot of you on the call today were even born. So tells you how old I am, but it also tells you how much experience I have. 10 years after going into clinical nursing, I got involved in the revenue cycle because I worked in a small rural hospital. And so I do know both sides of the hospital, both the financial and the clinical, which has been really great when I'm working with Hometown Health and helping hospitals understanding both sides of it. And I certainly understand the emergency room and all the challenges there. And we're going to talk a little bit about that today. So you'll be able to get CEUs for this today. As an IACET authorized provider, we offer CEUs for programs that qualify under the IACET standard. We're authorized to offer 0.1 CEUs or 1 credit hour for this program. In order to receive credit for this course, you must participate in this webinar in entirety or listen to the recording later, pass the post test that you guys will get with 80% or better, and submit a course evaluation. So you'll get a follow-up email, I'm sure, from Becky, and they will take care of that for you. And 1 hour CEU will be available for you guys. Okay, so by the end of this course or this webinar today, you should be able to identify the way to determine the type of patient that's overutilizing your ER, list the way a hospital is impacted by overutilization in the ER, recall different ways to determine where your focus should be, and describe solutions to overutilization of the ER. So, oh, they're still coming. Look, recognize who should be involved in ER care coordination, and provide at least one new idea for managing non-emergent patients in the emergency room. So section 1 is the problem, which is the overutilization in the ER. And we all know what that is like. We see a lot of patients that probably shouldn't be in the emergency room. So we're going to talk a little bit about that before we get into the case management part. The revolving door. So we all know that the ER is a revolving door for some patients that don't like to go to their doctor or don't have a doctor. Frequent flyers, or as they call them now, super users, can be seen multiple times in a day or week or month. Another type of patient in and out of the revolving door is the patient that has a chronic illness and is seeking a convenient time or place to be seen versus going with their physician. So it's up to you guys to figure out who at your hospital is overutilizing your ER. There's a million different reasons to do so. And so we'll talk about how to figure that out as we go forward here. Overutilization of the emergency room, of course, causes overcrowding in our facilities and decreased access for the patients who do have life-threatening issues. It also causes increased unnecessary cost to your hospital. I know as nurses, we don't think so much about cost, but personally, knowing the financial side, this is really a money-losing department for the hospitals. When there's an overabundance of patients that are not being seen for emergency conditions, we really don't have the staff to take care of them, especially in rural. So that creates a real burden on nursing services. Overutilization also creates an inconsistency in the care of patients who have chronic illnesses. So if they don't see their doctor routinely, then they're not going to get consistent care, which is going to create a vicious cycle of them being seen in the emergency room, then going to their PCP and back and forth, because there's just no consistency of care. It creates a poor patient outcome situation in your whole community. The continuum of care gets messed up. And we all know that I think it's tough on the psyche to see so many patients in the ER that are non-emergent. And you get kind of burnout a little bit more than if it was just emergent and urgent patients that you're seeing. So it takes a toll on the staff as well. So wrong care, wrong time, wrong setting. We're looking at that in the ER. So patients know, it's common knowledge now, that regardless of their ability to pay, we're going to see them in the ER. I mean, that's just going to happen. So people without those primary care physicians use the ER like they would a clinic instead of choosing a doctor for themselves. Sometimes it's just easier to do that for the patient. And other times it's just that the availability of that primary care physician is limited to the basic office hours. In addition, some providers refer patients to the emergency room, not for emergency treatment, but for convenience to their practice. I mean, how many times have you had a patient come in that's said, oh, my doctor sent me over here, or I called my doctor, they couldn't get me in, so they said, go to the ER. I mean, that happens a lot, right? So emergency rooms are used for convenience in many cases, and not just for the patient, sometimes for their primary care provider as well. After hours, if a pediatric patient gets really sick at home, the parents are really upset. They don't know what to do with the child. They have 105 fever. You know, they just need somebody to reassure them that their child's going to be fine. And sometimes the ER is used for that if it's after hours. So instead of waiting until the next day, they feel like they've got to be seen. So that's another situation that we see, of course. Now, episodic care in the emergency room just doesn't allow that continuity of care that a primary care provider could give to the patient. If they're seen at the doctor's office one day and the next week they're seen in the emergency room, there can be contraindications between medications. You know, the ER doctor gave one. If somebody's not doing that medication reconciliation, there's no consistency with any treatment regimen for their chronic illnesses. You know, us baby boomers, I can say this now that I admitted how old I really am, sort of, we're aging. So with that aging population is filling up your emergency room because you're filling in the gaps for the primary care providers, right? So there are a lot of people that are baby boomers that do use the ER for a clinic. They don't have insurance, maybe they're not quite old enough for Medicare. So they're kind of utilizing you as a go-between gap. between those two insurances. Wrong place, wrong setting. So in 2010, when the Affordable Care Act, or Obamacare, was signed into law, it was supposed to reform healthcare. And one of the things it was supposed to do was decrease the number of ER visits that the hospital sees. That was one of the goals initially, way back in 2010. A 2015 study found that it was not the case. Indeed, it found that instead 75% of ER providers reported increased usage of the emergency room. That also included patients with the marketplace health plans. It was supposed to, the Affordable Care Act was supposed to make sure that more Americans had insurance, and they assumed that that would help decrease emergency room visits if they had it, but that has not been the case, and it still is not the case, even after this study. That's not always the reason. I mean, they said, okay, we're going to get everybody insurance. We're going to have this marketplace set up where you can get it really cheap, and we're going to subsidize you. And that way you can go to a doctor instead of using the ER for a clinic as an uninsured. That did not happen. And you guys, I'm sure, know that. So as we all know, non-emergent patients should not be routinely seen in the ER as a clinic type, but we know that the clinics are busy and not always willing to see the patients. They may just be referred to the emergency room when the doctor doesn't have that appointment available, as we already discussed, but I know that some hospitals are starting to open urgent care clinics. I've seen that in rural hospitals in Georgia. I mean, the ER's here, and right next door is the hospital's urgent care, trying to redirect those patients. But those urgent care clinics also should not replace the primary care provider for that patient. We don't want them to not have a regular doctor. I tend to not go to the doctor as a nurse, and I'm sure most of you that are nurses on the call today can understand that. I think sometimes as nurses, we think that we can diagnose and treat ourselves, and it is good for everybody to have that primary care physician to follow up with them. So why choose the emergency room for care? Why do patients come? There are a lot of mental health issues that are not being addressed right now, and that's a comfortable place for those patients to go, or for law enforcement to bring them in to be seen. But we're also seeing an increased amount of mental health patients in our ERs just that are homeless from off the street. There's a shortage of regular doctors. We see a lot of drug-seeking behavior in the emergency rooms. You know, I think we've been talking about this overcrowding and overutilization of the ER for so many years. And a lot of it has been because of drug-seeking behavior in some of our patients. So that's a really big one to choose the ER. You know, they wait out in the parking lot to see which doctor's car is going to be there for the evening or for the weekend, who they know might send them in a prescription for some narcotics. Patients are really smart, and they know who's working in the ER, and they know when it'll be fruitful for them to go if they're exhibiting drug-seeking behavior. There's no access to specialists like pediatricians. So that's why in rural communities, especially if there's a lack of some service like OB service, and you have a lot of pregnant patients, that is one way. I think yesterday I was talking to my boss, and we were going through all the different hospitals that had got rid of their OB departments in Georgia. And I believe there were 12 in the past 2 years that have closed their OB departments. And so emergency rooms are starting to see those patients when they could be seeing an OB provider, but there's no access. Financial considerations. So the payment is very low for non-emergent care. I'm not sure what it is up there where you guys are, but I know in Georgia for our Medicaid CMOs or MCOs we have here in Georgia, they pay $70 for an ER visit no matter what you do as non-emergent. And then they expect you to appeal it to get more money. If you say, hey, wait a minute, this was emergent, they will send that. Sorry, y'all. Do y'all hear that vibrating? It's my phone, my boss. So payment decreases for non-emergent care. And then there's also payment bundling. So most nurses don't know this, but in the emergency room, say you do chest x-rays and lab, and you hang some IV fluids, maybe it's a level 3 or 4. and you've got all these different things. Many insurances only pay you based on the level. So they'll pay you a level 4 payment of $330 when you've done $5,000 worth of tests. So it's important to make sure that we're managing our resources well in the emergency room for financial considerations, because of the bundling that happens with just about every commercial insurance now. That's how they pay it, based on whatever level. And then no matter what you do, that's all they pay. EMTALA has that effect of decreasing collections of copays and deductibles. You know, we're so worried that we're going to get an EMTALA violation that we don't collect money. We don't talk to the patient about insurance until they've been medically screened, but then we go further than that, and patient access is afraid to come back because the nurses might get mad at them if we want to talk to patients about collections or their copays or deductibles. I want to encourage all of you that do work in the back, quote unquote, of the emergency room to really try and accommodate your registration staff so they're allowed to collect copays and deductibles to be able to keep you guys open, because like I said, it's the biggest money losing department in the hospital. So coordinating with your financial people so they can collect those copays is very helpful, because patients do use the ER to avoid payment for care. There have been, before we had to do electronic ordering of narcotics, or we're allowed to do some of that, the best way to get a patient to pay their copays and deductibles was to give those prescriptions, and it may still be the case where you are, to the patient access department. So the patient has to check in at discharge to get that prescription they're looking for. And at that point, they can ask for copays and deductibles. We do want more patients, more admissions, but we want the right type of patient. So stop for just a second here and consider any other reasons for ER overutilization in your hospital, because it's going to be different for everybody. Access is always a big thing in rural communities. And maybe you've had a lot of people lose their jobs from the pandemic that no longer have insurance. That's going to increase the utilization of your emergency room in some areas. So you need to really think about what's causing it in your community, because it will be different. So let's talk about possible solutions to the overcrowding of non-emergent patients in your emergency room. I'll stop. Becky, do we have any questions? I'll check with you on that first.
Not currently.
Okay,
at
great.
this time.
Okay, let's talk about possible solutions if you are seeing that overcrowding. Each hospital has to determine the root cause of that overutilization of the ER, right? So you want to start by identifying the super users or the frequent flyers by running reports. Any patients with over 10 visits in the last 12 months is a good starting point. If there's so many of those that you really can't narrow it down, you could do patients with 20 visits in the last 12 months. So you want to evaluate those patients and that you identify in your reports and watch for trends in maybe their chief complaint. I mean, are they drug seeking? The time of day, is it always after hours that they come in, or the weekend? Their insurance status, see if they have insurance or if they don't have insurance, because that's going to help you identify why they're utilizing the ER so much. If they have a regular doctor, their age, and socioeconomic issues. So the chief complaint. So every time the patient comes in, so you can run reports in your systems with the patient and their chief complaint as coded by medical records. So do they have the same complaint each time they present to the emergency room? What is it? Is it a chronic illness? Is it pain? Maybe they always have abdominal pain or back pain. They might have a chronic back issue. Are they identified as mentally ill? Do they exhibit those drug-seeking behaviors? And have they followed instructions from the prior visit? So that's looking a little bit deeper into the chart than the chief complaint, finding out if what they were instructed to do at discharge last time they did, which probably is a very low percentage, as y'all know. So with the time of day, do they come at the same time or different times for every visit? So that's important to look at. Weekdays or weekends, after normal clinic hours, And is there a pattern? So watch for patterns when you're trying to evaluate your frequent flyers or your super users and finding out about that insurance. So when they come in, we always ask them, who's your regular doctor? If that's blank on all of their visits, that's an important thing to note. You might need to help them with that. If they do have one, is that doctor local, or is lack of access to an out-of-town doctor part of your problem? And are they hospital affiliated, the PCP, or are they over 65 or under 12? Important to know. Okay, socioeconomic status. This is turning into a really big hot topic issue. Now there's a lot of different things that they're going to be adding to our diagnosis codes when we go to ICD-11, which is coming pretty soon, about socioeconomic status, including homelessness. That's going to be a really big focus of CMS. Do they have transportation? Are they employed? Do they show up in a cab every time they come to your emergency room? If you have cabs, I don't in my town, so that would not be something that we would see because we're very small. But are they employed? Are they disabled? Where do they live? Like, do they live with family? Do they live by themselves? Do they live with their cats? Are they documented alcoholics or drug use? Any of these things are really important to note, because you're going to find that a lot of your ER super users have multiple socioeconomic issues. So what are some other issues to analyze? You guys think about that and think about other things that might tell you a little bit about the patient, right? It's, I know we've gone a lot to checking boxes when we document. I'm kind of old school, where we used to do all that paper documentation or even charting by exception in a lot of text instead of checking boxes. But describing the patient, what you see in front of you, is important when you're an ER nurse, so that when other people go back and look at their record, they know what you were seeing. I used to do a legal documentation class back in the day, and I would say, in 6 months or 4 years, when this patient sues you, are you going to remember who they were? Will you remember what they looked like, what they smelled like? Who was this patient? Or are they just going to be a bunch of check boxes for you? So it's really important to give that visual of the patient as well. So that's another thing that you could look at in your notes.
Sandy?
Yes.
I did receive a question
Okay.
before you move too far away from your social
Sure.
drivers or those social determinants of health slide. Do you have an assessment tool that you use in the emergency room that you recommend?
There are some out there, and I don't have any off the top of my head. I don't think I have any in this computer, but I can get you some, Becky, for sure. And I'll send those to you, and then you can send them out after.
I know that several of our hospitals, just to make a comment, do use the Prepare Screener assessment, but they just wondered if you had any recommendations.
I don't off the top of my head. So I'm sorry about that, but I'll see what we can find for you for sure. And if anybody else that's listening in today has something really great that they use that's not necessarily attached to their EHR as proprietary, make sure you share that with Becky so that everybody else can look at that as well.
Yes, please share that in chat if you'd like to, the assessment tools that you're using. If it's different than, an inpatient assessment tool for the emergency department or any type of screener that you use, we'd appreciate that.
Yeah, that'd be great. Sure. There was a recent American College of Emergency Physicians study that said that frequent ER users were not necessarily more likely to make a non-emergent visit to the emergency department than the non-frequent ER. So just because a patient is a frequent ER user doesn't necessarily mean that every visit is non-emergent. In fact, those that were frequently seen in the emergency room were more likely to have mental health issues, drug-related or alcohol-related visits than the non-frequent ER user. So targeting patients that are frequent flyer or super users may not necessarily be the way to decrease that overutilization in your emergency room. Maybe you want to focus on all your patients with congestive heart failure. Maybe you're seeing a lot of those. Maybe it's not just you know, okay, so you've pulled this report and you've looked at all your frequent flyers, and what you're finding perhaps is that it's not what you thought it was that's creating the overcrowding. So how can you go about it differently? Looking at your congestive heart failure patients, maybe they're not being managed well, or maybe it's one particular doctor's patients that are coming more frequently. So figuring it out for your facility is going to be really important, and making sure that you're targeting the right population, right? So you want to determine if frequent flyers are the patients that are causing overutilization. Maybe you don't have as many as you thought you did. It's just that those that do come often have made a real impression on you, right? So you might need to change the focus with that diagnosis or the reason for the visit, and look at non-emergent and emergent patients, because an emergency can cause a frequent flyer patient as well. Like, you can't breathe because you have congestive heart failure, you're not taking your Lasix or whatever kind of medication that you're supposed to be on, it's still an emergency. So just because you're a frequent flyer doesn't mean it's non-emergent, is what ASAP was trying to say. I mean, you can be an emergent frequent flyer as well if you're non-compliant. So that's important to look at. So you want to pull reports that are identifying your patients with level 1 and 2 ER visits. Okay, so those would be the ones that are non-emergent, right? Those are the most likely, level 1 and level 2. You can pull it by level, and then choose a focus to narrow if that's a large list, or if that's not a big list, level 1 and 2, maybe they are those emergent patients that are frequent flyers. So you may need to pull reports identifying more. Here's an example though. Pediatric patients with non-emergent diagnosis are most likely to present after office hours. And kids are more likely to have a fever after dark. If you have kids, you know that. I mean, in the evening, kids get fevers. I don't know why. It's something about their circadian rhythm, I suppose. But maybe there's only one pediatrician in your town and they close at 5 p.m. Then that's a patient population, which is pediatric fevers. And the barrier, which means there's no further access after 5 p.m., that's creating a lot of non-emergent visits in the pediatric population. So you can identify that with these reports as well. So to identify and overcome these barriers, you want to use community education. It's really important in our rural communities. You know, I heard Becky and someone else talking about the community health needs assessment. You guys should go on your website and look at those. They really have great information. We have universities that help hospitals do those. Know what's going on in your community, know how to educate your community and ways to reach out to them, even if it's Facebook. You know, I mean, social media is a good way. You may want to redesign your primary care services. If the physicians in your area are part of your hospital, if they're employed by the hospital, maybe you want to redesign the hours, find ways to connect patients to the appropriate services, use your case managers, which I know there are on the phone today, and implement pharmacy participation as well, making sure that you guys are doing those medication reconciliations and that you're working with pharmacies both in and out of your hospitals. So
And
for case,
Sandy,
yes,
I was
ma'am.
going to say, I might interject here too,
Sure.
that the community needs assessments are provided by the Indiana Rural Health Association. So if you have questions about your community needs assessment, why, please reach out to either myself, and I'll connect you with Allie Orwig at the Rural Health Association if you do have questions about those. And I'd also would like to say, and Allie provided, I'll share Allie's email address in chat here in a minute. But also there's a lot of good work going on around the state, either to make improvements through their community paramedicine programs, or people are building new community paramedicine programs. So if you need some connections on best practices there, why, again, reach out to me and I will connect you with the appropriate people at the state. But it's a great way to address some of those patients that you may be able to partner with to address some of the issues at home for people that are often returned to the ER, particularly for really emergency types of situations. situations so that early intervention can take place. So I will share Allie's email address in chat for the community needs assessments if you have any questions, and reach out to me if you need any additional assistance with community paramedicine programs.
And maybe you've never heard of a community health needs assessment. It's called a CHNA, but I promise you, if you go to your hospital's website, it'll be right there on the front page for you to click on to read. And a lot of work goes into those, a lot of work to let you know what's really going on in your community. So thank you so much for that, Becky. Okay, so I know somebody's going to ask me if I have a template for this. I do not, but it's helpful to have some type of template. You might want to create one that works for your hospital to create patient profiles and care plans for the patients that you want to really watch closely. Say you've identified some of those congestive heart failure patients and you want to really focus on them. Let the patient know and keep them the center of that plan and allow them to have input on the care that they receive. Keep that plan updated with any new visits that they have and any changes in your goals. So you want to discuss those care plans in ER staff meetings, include social workers, physicians, pharmacy, therapy if needed, and make sure everybody's on the same page. So if you're monitoring some of your patients specifically in the emergency room, everybody needs to know that, even the patient. So if you're trying to redirect them to PCP and they just won't go, you might have to manage their care from the emergency room and build a relationship with them so that you can involve those other community resources when appropriate. Okay, let's get more into the case management side here of the emergency room. So by the end of this part, you should be able to describe the case manager's role in the emergency room, identify the benefits of having case management in the ER, and list specific tasks the case manager performs to improve patient outcomes. So first I'll say, every rural hospital I've ever been in has told me there's no way, we don't have enough people. We cannot staff the emergency room with case management. So I get that. I understand it. So we're going to be talking about that perfect world that none of us live in a little bit today. We're talking about managing care with case management in the ER. So they'll be monitoring utilization of services, managing coordination of patient care in and out of the hospital. One thing we're doing in Georgia right now, and you may also do that, I'm not sure, in Indiana, is working with our Medicaid managed care to try and get them to communicate better with our case managers and our discharge planners to be able to coordinate that care. We hear a lot from these care management organizations about how they manage care, and we don't see a lot of that care management. So I think the hospital is left out of those conversations with the insurance companies, and we need to kind of insert ourselves a little bit to make sure that care coordination is being done by these insurance companies and that we're a part of that conversation. We want to maximize the healthcare dollar through efficient resource utilization, financial and patient care management. So maximizing the healthcare dollar is a big deal. You want to limit inappropriate or unnecessary care that we see a lot in our emergency rooms. So patient care management, that limitation of inappropriate and unnecessary care. Do you have a doctor in your emergency room that orders a CT scan of the head on everybody with a headache, or a pelvic exam with everybody with abdominal pain? That's females, of course. Is there a doctor that always does a CT scan of the head for sinusitis? We used to have a doctor like that. I swear, bless him, love him. I think he's still around, as a matter of fact, so I won't name him. But limit inappropriate and unnecessary care, because that will help you promote positive outcomes. You don't want to be doing things that are unnecessary for the patient. And some doctors just get in a habit of doing tests that don't need to be done. My rule of thumb is always, if you're not going to use the results of what you're doing, then don't do it. For instance, ordering an HIV panel or ordering a hepatitis panel, that has to be sent out in most rural hospitals to LabCorp or another lab company, you're not going to get that information back before the patient is discharged home from your emergency room. So why are you doing it? Right. So we want to make sure that those tests that we're not going to use for our care in the ER are not being done. So it's unnecessary if you can't use it to treat the patient. Right. That'd be nice if that information went to a doctor who called the patient, et cetera, after discharge, but that we know that doesn't always happen. And so anything that's unnecessary doesn't need to be done while the patient's there. It decreases unnecessary testing and costs to both the hospital and the patient. If they have really high copays and deductibles, it's costing the patient a lot of money for you to do unnecessary testing. Using step treatments is also important. Like, did you do an x-ray before you did that CT scan? Lengths of stays can be reduced with appropriate resource utilization, both in the emergency room and in the hospital. So if you're case management in your broader hospital area, you know that if we're having to wait until Wednesday for the echo tech to come in to do this echocardiogram and the patient really is ready to go home on Monday, it's not really great resource utilization to have the patient stay 2 more days, possibly have those days denied by your insurance company just to wait for the echo tech. Can we discharge them and bring them back for testing, both in the ER and on your medical surgical floors? So one of the things I think that hospitals don't understand and patients don't understand is that we really are a business. We're in the business of delivering healthcare, but we're a business. And so finding ways to cut costs without decreasing quality is important so that our businesses, which are our hospitals, can stay open. It's important for us to collect money. That's why I want you guys encourage the clinical people to coordinate with the financial people in your emergency department. We have to find ways to keep our hospitals open. And it's really important to make sure we have good resource utilization and we have good collections as well. Excuse me. ED case managers. So what emergency room case managers can do is reduce your denials on your admissions, right? So if a case manager is in the emergency room and they're reviewing the admissions, first of all, they'll avoid the inappropriate admissions. Second, they'll decide whether the patient should be observation or inpatient, which clinical people know we treat all patients alike, whether they're observation or inpatient. It doesn't matter to nurses what status the patient is in, but it matters to the insurance company. It matters to Medicare. It's all semantics really, but it really affects your payment. You don't want it to be an inappropriate admission or your insurance and Medicare won't pay for it. You don't want it to be inappropriately 7 days of observation if they should have been inpatient. So it's important to get that correct status assignment, and the case managers in the ER can really help with that. They can improve patient care and improve discharge planning. You know, discharge planning, we hear it all the time, starts the day the patient's admitted. And if the case manager's in the ER, then of course that would be great to start it down there. To reduce denials, you want to involve case management early. So say you can't have them in the emergency room, making sure that they're aware of all admissions from the ER and giving them as much information as possible. Using case managers at all points of entry would be the perfect world. Say you have one in the ER, you have one in the OR, doing all this great admission screening criteria. Perfect world, right? That would reduce denials. We do the best we can with what we have in rural. And so making sure that case managers have great communication channels with all those points of entry is more realistic. Okay, inappropriate admissions. Case managers, I was case manager for 4 or 5 years, I guess. Lack of physician documentation to support medical necessity is a really big thing. So it's my opinion, and just from experience, that doctors really don't order that many unnecessary tests, but they do lack documentation in why they're ordering it. So it's in their head. It's just getting the information on why they're doing something to that chart. And that's a really difficult thing. And that's a job of case management to kind of pull that information out of the doctor's brain and get it to the chart so that we can support the medical necessity of whatever they're ordering. So they're not just ordering a whole bunch of labs because they just felt like that was a Wednesday thing to do or the Tuesday thing to do. There really is usually a reason, and it's pulling that information out of the physician and getting it to the record that falls to case management in a lot of cases. And then they also lack a lot of knowledge about inpatient versus observation, as I'm sure you've seen. I had one yesterday, actually. I was at a hospital and they said that they had a 7-day observation patient. I said, oh my gosh, why? Why was somebody here for 7 days under observation? And they said, because she was here 2 weeks before with the same exact diagnosis and she was inpatient. Okay. They were afraid that if they did 2 inpatients within 2 weeks of each other with the same diagnosis, that they wouldn't get paid. What they didn't realize was that putting them in 7 days of observation, they were not going to get paid. Okay, you don't get that authorization for the inpatient. So there's a lot of misunderstanding between inpatient and observation, and the case manager needs to know what is important to each of those statuses and how to help the physician determine that status. Now, when we moved to coding diagnoses using ICD-10, it became more necessary for physicians and nurses to document using really specific language, right? Has to be clear, complete, and concise, and in the record, not just in the doctor's brain, to support that medical necessity. So case managers, you should know what's needed to enable your coders to code to the highest levels. So one of the things, like for instance, if somebody falls at home, it's not enough to say patient fell at home with ICD-10. You have to say they fell at home and hit the cabinet with their left arm on the tile floor. You know, all that stuff can be used to narrow down and get a better description for the ICD-10 code. So with ICD-9, patient fell at home was fine. But with ICD-10, you have to give a lot more specificity. And so you have to pull that out of the doctors to get them to document the correct diagnoses. Missing or incomplete documentation, of course, can lead to medical necessity denials. And when a coder has to keep asking the physician or querying the physician for more documentation, it slows down the coding, the billing, and your reimbursement. And the key is to get that money in the door quickly as possible so we can all get a paycheck, right? So when you have to query the physician for more information, that takes time. So before the chart gets to medical records, speaking in the abstract because it's all electronic, before it gets to where it's time to be coded, the case manager has that physician right in front of them to get that documentation. So make sure you're reviewing your doctor's documentation as they go from the ER to the floor and then to discharge and coding, to make sure that all the documentation needed is in that chart, so it doesn't slow down the rest of the revenue cycle.
And Sandy, I did receive a comment directly to me that that's a very good point, that we don't spend enough time educating staff on what is good documentation from a billing perspective. So
Right.
That's a very good point.
Right, yeah, and talk to your coders. I think I really like to encourage hospitals that they include clinical staff in their revenue cycle meetings. If you've never heard of the revenue cycle, you are not alone. I remember as a case manager that I would hear people say revenue cycle and I didn't know what they were talking about. All that means is that's the first contact with the patient all the way until their balance on their bill is 0. And everything that happens in between is the revenue cycle. So it's, making sure that the charges are in, injections, infusions, and labs and radiology, all those charges have to be captured. The documentation has to be there in the chart, and that's where clinical helps a lot. You have to make sure everything is documented and the reason why. And then it goes to your medical records department. They code from the documentation that you put in there. Coders are real funny about not coding anything that they don't see in the chart, right? So you say, well, he had such and such, but if it's not documented, it wasn't done. So if it's not documented, it's not coded, and that can create a lot less payment for your hospital. describing a congestive heart failure patient. Is it acute? Is it acute on chronic? Is it just chronic? Is it atrial? Is it ventricle? Is it whatever kind of CHF there's a lot of information that needs to be documented about that little heart that patient has and how it's working to be able to get higher payments, right? So if you have a patient in the hospital, say that has pneumonia, or we'll stick with CHF. So CHF patients should be there for 5 days. And if you're being paid on DRG, which a lot of you are from your insurance companies and Medicare, they're going to pay you $10,000 and no more, or even less, probably $7,000 for a congestive heart failure patient. And that's it. So no matter what you do for that patient, it doesn't matter how much medication, how many exams, how many tests that you do, you don't get any more than that $7,000. That's it, right? So that's resource management, number one. Also with the documentation, the more they document, the higher that congestive heart failure DRG is going to be. Maybe it has other complications. The patient also has pneumonia with the CHF. They also have diabetes, but if none of that's documented, they won't code it, and so your payment's going to be reduced. So that is important to make sure that clinical staff is educated for that. So it's always great to have a physician leader that can communicate with the other doctors, because let's face it, doctors prefer to be told things by other doctors and not by nurses, right? So it sounds misogynistic, but we do have female doctors as well that don't want to hear from nurses necessarily. So if you have a physician that can be your champion, that can help you communicate with the doctors, maybe if you have to call them to kind of interpret what you're telling the doctor, that would be great. So making sure they're admitted to the correct status, as I say here on the slide, and making sure that the medical necessity documentation is there may help if you have a good physician leader that can communicate with the doctor. So you want to be the patient advocate, the right patient, the right care, the right time, and the right setting. That's your case management role, to make sure all those things are right. Screening criteria, doing admission screening criteria verifies that the stay is medically necessary. They should be inpatient versus observation. And case managers need to be trained to apply the criteria correctly. It's really very simple. So I'll just give you my short little description of patient status for the case managers that are either in the ER or on the floor that's looking at what status to put the patient in. Observation is only for determining if a patient needs to be inpatient, right? So say you have an asthma patient in the emergency room and the doctor's like, we can't get this to break. They're going to need more treatments. We need to admit them. Do we really need to admit them? Probably we need to put them in observation for 24 hours to see if we can get this to break, enough respiratory treatments. And then all of a sudden they're feeling better. You've given them steroids, whatever they need. And the next morning they're better and they can go home. So that's what observation is for. If they don't get better, at that point, you change them to inpatient. Medicare has a 2 midnight rule. What they're saying is that if the physician thinks the patient will be there longer than 2 midnights, they should be inpatient. It's pretty simple. If they're going to be there longer than 2 nights, they need to be inpatient. But documentation supporting that decision should also be in the chart. So observation is just to see if they need to be inpatient or if they can go home quickly. And then inpatient, if they're going to be there 2 nights, they need to be inpatient. But making sure that documentation is there is important as well. So when correctly applied, your screening criteria can reduce unnecessary admissions and ensure appropriate hospital reimbursement. We do see a lot of social admissions in rural, it's Christmas, the family's going out of town. It's really not acceptable. Okay, so keep that in mind as well. I'm not sure if I am going to talk about that on another slide, but developing good relationships with your physicians and the emergency room staff allows case managers to use their expertise in applying screening criteria to the patients at the time of admission. So even if you can't staff a case manager in your emergency department, make sure that that case manager has a good relationship with the ER nurses, because ER nurses will let you know what's up with the patient, right? So have a good communication with the nurses and with the doctors. So you want to start in the emergency department, determine the busiest time of day, route any direct admits through your emergency department so they're not showing up on the floor, and so that the case manager can take those admission orders over the phone. So that's how you want to start if you're going to put that case manager in the ER. As I said earlier, discharge planning begins at admission. Focus on the patients that are at high risk for poor discharge outcomes. It gives you faster transitions to alternate levels of care. Okay, so if you don't start the discharge planning at admission for a patient, and the doctor comes in the morning and he says, I'm gonna send Bessie home today. You're like, oh no, I haven't even contacted home health or the nurse at home or wherever the patient needs to go. She doesn't have Meals on Wheels. So if you started admission and focus on those high risk patients, you won't be caught flat-footed at the end when the doctor comes in to send them home. The caregiver and family is usually with that patient in the ER, which is why it's a good place to have case management, because you can start to develop that communication with the patient, the relationship with the patient's family, and then evaluate talking to the family so you're not bothering the patient as much, what community services they already have in place, if they need any equipment at home, or if they can't be home, if they need to be going somewhere else. It's important to remember, okay, during the pandemic, we've been able to move patients to swing bed or to nursing homes without those 3-day inpatient stays. That's going to go away pretty soon, since President Biden just said the pandemic was over where he's at. So if that emergency declaration goes away, all those flexibilities that we have had for the last 2 years are going away as well. By the end of the year, when they say that the public health emergency is over, we're going to have till the end of that year, whatever year that is, this year or next, to use those flexibilities. And one of those is to make sure that patients have a 3-day inpatient stay before we can move them to a nursing home or swing bed. So a lot of hospitals got used to not having to do that and kind of took advantage of it a little bit. So remember, that is coming to an end. So also with communication, patient families or caregivers you need to communicate with, their primary physician provider, any referrals, and of course the staff nurses. So who's taking care of the patient, because it's not going to be the case manager. So make sure you're communicating with staff. So for case management in the emergency room, you can reroute patients to less acute levels of care once they've been medically screened. You know, you could send them to their doctor or help them find a doctor, identify frequent flyers, assist patients with identifying a medical home. That's a really big push right now, is those medical homes. Identifying the frequent flyers, which we went over this, is patients with greater than 6 ER visits in less than 6 months is a good rule of thumb. You need to initiate contact with that patient and find out why. Once you've identified them, why are they coming so often? Send a letter to the patient and to the doctor to let them know that you're managing and watching this patient because they are a super user, and link eligible patients to disease management programs and do follow-up. So just because we identify our ER frequent flyers or super user, that really doesn't do anything, right? Just to identify them. So you want to do more. You want to contact the patient and do all these things and make sure that you're providing them with resources so they don't have to come to the emergency room. I mean, surely nobody likes it, right? I wouldn't think so. So avoidable ER use is the lack of a medical home, lack of education, if they have a chronic disease that's out of control, and behavioral issues, which we identified in the first portion. So we want to decrease lengths of stay when they're admitted, decrease our denials for medical necessity, increase communication in our community and with our patients, and increase revenue for your hospital so we can all get paid. So getting started with case management in your emergency room, you may think it's an impossible thing because you don't have the staff or you don't have the time, but start slowly, you know, get your CFO to buy in or your CNO to buy in on it. To spend time in the emergency room, maybe even just a couple hours a day. If you have more than one case manager, maybe reallocating those tasks to start slowly. Then you can evaluate any outcomes. Maybe you have identified frequent flyers and you've seen great things, you've decreased the number of visits they have. So evaluating your outcomes and being able to show that will justify maybe getting more staff to help you in the emergency room. Use your imagination. I don't have a really great imagination, but there are a lot of people out there, and I'm sure that are listening that have great imaginations. I do painting, but I'm not real good at thinking of what to paint. I have to have a reference to paint because my imagination is not as strong as some other people's. So if you have great imagination, use that to create new and innovative ways to overcome any barriers at your hospital for patients and for staff. Coordinate with other disciplines and outside resources. Allow other voices to participate. Allow those people that are really innovative and creative to help you figure out ways. The community paramedicine that Becky mentioned is a great way also to keep you from having all those frequent flyers, finding ways to put our people in the community to help these patients. A lot of times they might just be lonely, right? And they just come to the ER because they like you guys. And we see that a lot. Or even patients that are on the med-surg floor that don't want to go home. I'll tell you a quick little funny story. My dad is going to be 90 in December. He's so fabulous. Anyway, really super bright, had a hospitalization recently and had to go to a swing bed. And within 3 or 4 days, he was great. He was fine. Could have brought him home. He gets around. He's a little unsteady, but he's pretty good for 90. He rides his exercise bike an hour a day, but he was bound and determined to stay for 21 days. Which he could for swing bed. He said, nope, it's a 21-day program and I'm going to stay. I think he just kind of liked the nurses and wanted to hang out up there and get pampered myself. So he stayed his whole 21 days and he did great and he came home. But a lot of times patients just want to stay, even if it's not for a great medically necessary reason. So we have to watch that and make sure that they are covered and they're able to stay. And fortunately, he has Medicare, so he was, and he did great. And he'll probably want another 21-day stay eventually. And I'll be glad to send him over there. So he's fantastic. Okay, so now, yes, ma'am.
I thought now would be a good time to share too, that if you haven't connected with the Indiana Recovery Network for patients that have substance use disorder, they're a peer recovery group that can work with the hospital, and at times when it's appropriate can come into the ER to start to work with patients. And they've also, depending on the circumstances, been able to help with transportation kinds of issues for those substance use disorder patients, as well as placement for those patients maybe that are requiring an inpatient stay. So when I conduct a follow-up, I will share information. The group have regional divisions, and if needed, I can help facilitate connecting you with the regional group. But I know that the substance use disorder patients coming into the ER have increased over the period of the COVID activities.
Right.
So I just thought it was a good time to share that information.
Absolutely. Absolutely. Yeah, that is really important to remember that this pandemic has really messed us up with mental health and drug use and a lot of suicide and suicidal ideations. People are lonely. It was a